Very good morning. So let's dive into the part two of diabetes mellitus. So a quick recap of what I taught you yesterday. So we all know that insulin is one of the very important hormone which is secreted by the beta cells of pancreas that controls the glucose levels. So any impairment in insulin, either the cells do not take up or there is decreased production, the blood glucose levels is going to get spiked up. Okay. So moving on, I'll tell you the few very important investigations and why we are taking it, and also we'll talk about the treatment. Okay, so the visceral fat, the abdominal fat, the visceral fat, which is more in obese patient, as I told you, the outermost layer becomes hypoxic. They are released into the bloodstream, and also there is a production of very important enzyme called hormone sensitive lipase. Right, as I told you yesterday, there's going to be synthesis of hormone sensitive lipase enzyme. So these hormone sensitive lipase enzyme, what it is going to do is, it is going to release increased amount of free fatty acids. So these free fatty acids, they go and deposits in the liver in the cells. Okay, so they go and deposit in the form of diacylglycerol. Okay, DAG. So this diacylglycerol is an enemy for us. Okay, this diacylglycerol, it is going to impair or it is going to distract the signaling of insulin. Okay, so this is going to result in impaired insulin signaling. Okay, so imagine when I'm taking a food, the body is going to break it down and the blood glucose level going to spike up, and later the insulin comes into action. It is reduced, it directs the glucose to the cells, organs and various parts so that the blood glucose levels remain normal. What happens if I don't take a food? The liver is going to increase the production of glucose. Gluconeogenesis is going to take place, and it is going to supply the glucose to the bloodstream, and the body functions normally. And you have to remember one thing, that even in a fasting state, the glucose is controlled by insulin. Even though the liver is controlling it, the insulin, it controls the liver to produce, or it says the liver, okay, this is enough, this amount of glucose in the blood is enough, you stop producing glucose. Okay, so it controls gluconeogenesis in the liver even in a fasting state. So now what happens, the first investigation what we are going to do is the fasting blood glucose levels. Fasting blood glucose levels. So fasting blood glucose, as I told you, the patient is not having food for at least 8 to 12 hours. So 8 to 12 hours of fasting, no tea, no coffee, no calorie intake. So I'm giving the blood to the lab. Okay. So these patients, they primarily depend upon the hepatic output, obviously, right? Because I'm not taking food, I'm depending upon my liver to release the glucose, gluconeogenesis synthesis by the liver, and the liver controls the blood glucose level. As I told you earlier, even though the liver is producing glucose, even in a fasting state, insulin will act upon the liver saying, okay, it is fine, it is not fine, something like that. So in this state, fasting blood glucose in diabetic patient, there's going to be insulin resistance. So will the liver get signals from the insulin to stop glucose production? No. So even in a fasting state, the hepatic glucose is going to be more. There is going to be increased gluconeogenesis by the liver. That is going to result in increased blood glucose levels. This is the reason we are taking fasting blood glucose. So fasting blood glucose directly reflects your hepatic output. Okay, the body solely depends upon the hepatic gluconeogenesis, but because of the impaired insulin signaling, either because of diacylglycerol, the or free fatty acids which is released, the liver is not getting sufficient input from the insulin to stop the production of glucose. So there's going to be increased glucose production in the bloodstream. One. So I'll tell you the normal values in the upcoming slides. Okay, so let's talk about why these blood tests are taken. So first investigation what we take is fasting blood glucose. So the next one is postprandial blood glucose. So postprandial blood glucose means, imagine I'm taking the food, I'm having increased blood sugar levels in the bloodstream. Okay, so the carbohydrates are broken down into glucose. It is enters the small intestine, then it enters the bloodstream. Okay, after 2 hours, the blood glucose should be controlled, or it will be controlled by insulin. So insulin will signal the glucose to enter into the cell's organs. So imagine after 2 hours of the food intake, still my blood glucose level is increased, then there is a defect in peripheral resistance. So in the first fasting we talked about hepatic insulin resistance. Now we are going to talk about peripheral resistance, that is the muscles, the cells do not take up insulin. Why? A small recap. So in the cells we have GLUT4 actions. So increased free fatty acids, they are going to result in impaired or decreased GLUT4 movement towards the cell surface, so the glucose is not taken up by the cells. And in the muscles, obviously there is going to be decreased formation of glycogen, again because of these free fatty acids, diacylglycerol, all these things. So the peripheral take up of the glucose is reduced, that is the muscles do not take up to produce glycogen, the cells do not take up glucose to produce energy. So postprandial blood glucose will be elevated in patients with diabetes because of peripheral insulin resistance. Peripheral insulin resistance. Okay, the next one investigation what we can do is HbA1c. Okay, HbA1c means, see, the glucose, it binds to hemoglobin irreversibly. Okay, so the glucose is bound to hemoglobin, and the lifespan of RBC is 120 days. So what happens? It gives the blood glucose level for 3 months. Okay, so there will be no fluctuations because it's a very standard investigation, because the insulin, sorry, the glucose, it binds to the RBC irreversibly, or it binds to specifically hemoglobin irreversibly. So I can see the blood glucose levels for past 3 months without any kind of deviation. Okay, I'll talk about the normal values in the upcoming slides. Okay, so these are all the very three main investigations which we should take. Apart from this, there is something called as urine albumin to creatinine ratio. So urine albumin to creatinine ratio, if you see, there will be destruction of the glomerular basement membrane in patients with diabetes. Why? Because of the increased glucose load, the glomerular basement membrane is getting damaged. Okay, so the glomerular basement membrane is getting damaged. So what happens? The proteins, instead of reabsorbed, it is getting excreted or absorbed. Okay, glomerular basement membrane is destroyed. So because of this destruction, there's going to be increased excretion of proteins like albumin and creatinine. So normally, if you see, it should be less than 30 mg per gram. So in case of microalbuminuria, it's going to be 30 to 300 mg per gram. Okay, so till now we have talked about 4 investigations: fasting, postprandial, HbA1c, and urine albumin to creatinine ratio. The next test what we can take is triglyceride level. That is, to be specific, lipid profile. Okay, so in the lipid profile I can see more amount of triglycerides. So these are all the very basic investigations which you should take for patients with diabetes mellitus. Okay, fasting, postprandial, HbA1c, urine creatine to albumin ratio, and then triglyceride levels. Okay, so now we are going to treat based on the investigations. Okay, so imagine if a patient comes to you with diabetes, so you should know what are all the medications they are taking and what is the dosage they are taking, and that is how you determine a patient whether they are highly prone for any infections, or you should wait or give antibiotics before the procedure. Okay, so you should know the basics of diabetes and the medications what the patients are taking, the dosage, and a few very important stuffs. So every time you see a diabetic patient, you don't get scared. Okay, so these are all the normal values of fasting, postprandial, HbA1c, and random blood glucose. So fasting, so normal will be less than 100 mg per dl, and for pre-diabetes is 100 to 125. You have to memorize these values, and for diabetic it is more than 126 mg per dl. For postprandial, it is less than 140 is normal, 140 to 199 is pre-diabetic, and more than 200 mg per dl is diabetic. HbA1c less than 5.7 is normal, 5.7 to 6.4 is pre-diabetic, and more than 6.5 is diabetic. So for random blood glucose, more than 200 mg per dl plus symptoms like polyuria, polydipsia, polyphagia, we can consider the patient as diabetic. Okay, so these are all the normal basic values which you should be aware of so that you can interpret when somebody gives you the investigation. Fine. So the first medication, okay, the first medication what we are going to take is, it is going to be first line, that is the anti-diabetic drugs metformin. So metformin 500 mg per day, okay, once daily. It can go up to 2000 mg. The next one will be metformin is followed by sulfonylureas, glimepiride 4 to 10, 1 to 4 mg per day, once daily. Okay, so the third important drug is DPP4 inhibitors. What do you mean by DPP4 inhibitors? Dipeptidyl peptidase inhibitors. Okay, so these dipeptidyl peptidase inhibitors, they are going to inhibit what is called as incretin hormones. So these incretin hormones like GLU, okay, so these incretin hormones, they are going to reduce the insulin secretion. Okay, so DPP inhibitors reduce the reduce the glucose levels by reducing the incretin hormones. Okay, so DPP4 inhibitors is sitagliptin, 100 mg once daily. Fourth important drug will be sodium glucose cotransporter inhibitor. Sodium glucose cotransporter inhibitor, because more amount of glucose is getting excreted, so I'm just inhibiting the transporter. So it will be empagliflozin. Empagliflozin. So the dosage of empagliflozin, if you see, it will be around 10 to 40 mg once day. And for triglyceride level, we can give atorvastatin 10 to 30 mg per day. Okay, so and for secondary, any kind of secondary prevention, we can give aspirin. Prophylactic dose 75 mg per day. So these are all the very basic drugs which the patient will be taking, and you should be aware of it. Metformin, glimepiride, DPP4 inhibitor, sitagliptin, dipeptidyl peptidase inhibitor, which inhibits the incretin hormones, and then which is followed by sodium glucose cotransporter inhibitor, empagliflozin, and then atorvastatins. And for secondary prevention, we can give aspirin. Okay, so with this, the very basics of diabetes mellitus comes to an end. And very important thing, all these are given for type 2. And one more thing is, for type 2 patients, if the HbA1c is more than 10, okay, and if the patient is having fasting blood glucose of more than 300 mg per dl, then we should go to prescribe insulin 10 units per day. Okay, this is for type 2 diabetes mellitus patients. For type 1 diabetes mellitus patients, the only treatment is insulin 0.4 to 1 unit per kg, okay, per day for type 1 diabetes mellitus. So for type 2, we can prescribe these drugs: metformin, glimepiride, sitagliptin, empagliflozin, atorvastatin, aspirin. And if there is severe hyperglycemia like HbA1c of more than 10, FBG of more than 300 mg per day, you can give insulin 10 units per day. And for patients with type 1 diabetes mellitus, we can give insulin 0.4 to 1 unit per kg per day. Okay, so this is the basics of what the investigations, and we talked about what is the types, what are the pathophysiology, what is the clinical features, what is the investigations, and what is the treatment of diabetes mellitus. So this is very important, and I hope this makes sense. So thank you so much for watching the video. Have a nice day.